Welcome to Plenary Session 5, a live case session entitled Enhanced Redo AF Ablation with High-Density Mapping with the Dual RF and PF Integration. This is from case operator and RIO co-director, Dr. Julian Chun, David Schaack, and their team in Frankfurt. Before we join the team, let's meet our panelists. Dr. Matthew Michelop from Jacksonville, Dr. Andrea Sarkozy from Brussels, and Dr. Andreas Metzner from Hamburg. Let's meet our team. Julian.
Thanks again for having us. Welcome back to Frankfurt, CCB, at the Markus Krankenhaus. And it's our super great pleasure to present a very challenging case, I have to admit. But we will see how it works together. With me here on the table, at the table, it is Dr. David Schaack.
Hello.
And of course, not to forget, again, you know probably her face is not only the queen, but also the princess of our cath lab, Silke Reda. And of course, she's taking care of all sedation issues, because this patient also is in deep sedation, and she will assist us with all the, let's say, material. Before we jump into the case, maybe David, you can share with us why this case may be very complex.
Yes, I'd love to. It is a very challenging case, as you already said. We are treating a 76-year-old woman with a CHA2DS2-VASc score of 4.
I need to see the slides. Yeah,
oh, yeah,
perfect. Yes.
Yeah, can you go ahead? Yeah, perfect. She had persistent AF actually, and already underwent 3 ablations, which was 1 CTI ablation, then 1 PVI with an left atrial anterior line and the left atrial roof line. And then she had recurrent atrial tachycardia and came back where a roof-dependent tachycardia was identified and treated with a new roof line, and also a gap in the anterior line was identified, and she received a new anterior line. And now she has recurrent atrial tachycardia again, organized atrial tachycardia, not atrial fibrillation. And because we already did linear ablations twice, we decided to this time use the toggling PF and RF catheter to probably close the gaps in the lines. This is the ECG she presented with, and if you look closely, you will see the P wave, so the 2-to-1 conducted atrial tachycardia, which she is in right now as well. So she stayed in the tachycardia. The device we are using is the Sphere 9 catheter from the Afera system. It is a 9mm diameter lattice tip catheter. It's quite flexible. If you have it in your hand, you will feel that it is quite compliant. So you can sort of push it against the wall to get contact for the electrodes. You have 9 microelectrodes, and you can use unipolar pulsed field ablation as well as radiofrequency ablation with it. And we will probably also see both in action today. And we also use the same catheter for the mapping, which is, I think, a nice feature. We don't have to switch the catheter for the map.
Yeah, super, David. Thank you. Maybe you just briefly show some parts of the anatomy, because, again, we did 2 transeptals. We have 3 sticks now in the groin. I mentioned the patient is in deep sedation. We use Afera on our daily routine with deep sedation. This is the German thing. And as David mentioned, it is a monopolar PF. And this, of course, may also interfere with, let's say, skeletal muscles, and maybe also with sedation. This is why at least it may be considered a little different to the bipolar experience, I would put it this way.
Definitely. Can we probably see the X-ray? Then I will review some of the X-ray pictures we already did. So what we did, we always start with selective pulmonary vein angiographies, here using a multi-purpose catheter. We do this for all our technologies to really try to understand the PV ostia and the left atrial anatomy. Other than this and the transesophageal echo to rule out thrombi, we don't do any pre-procedural imaging in this case. And that's the left inferior pulmonary vein. And
with 2 branches, it's not, it's not stenotic.
No, yeah, right. You can't really see the inferior branch till the last second of the slide, but there's no stenosis, that's true. That was in a left anterior oblique projection. That's the left superior pulmonary vein, and an RIO, right anterior oblique projection, and the same in the LAO projection. And then we can see the right superior pulmonary vein in the RIO projection. And last but not least, the right inferior pulmonary vein in the RIO projection. And this gives us quite a good understanding of the anatomy of where we are with our sheath and may help us with the mapping.
Yeah, wonderful. With regards to the electrograms, maybe have a look to the electrograms one more time. We have, as I said, 2 transeptal punctures performed. One was actually passive transfer, one anterior, one a little posterior. A spiral catheter, which is sitting in the left atrial appendage. And we like to have a second catheter on the left side whenever we deal with left-sided tachycardias. And we also have the second transeptal axis and the sphere 9 catheter, which is sitting there. And this corresponds in the electrograms. Here you see the electrograms in pink. You see the signals from the lasso, and the lasso is, or the spiral catheter is positioned inside of the left atrial appendage. In green, we have the coronary sinus activation, and maybe just one sneak over to the fluoro. Here we have the fluoro, and here this is the current catheter positions. You see the catheter, the sphere 9 catheter, is also positioned inside of the left atrium. So I think we are ready to start the map, and we take you basically on this journey. And keep in mind, this patient is a repeat procedure, and including PV isolation. He was also treated externally, but also in-house, and substrate modification last time, correct?
Exactly. So we expect at least quite a lot of scar in the left atrium, even if not natively, then definitely from the prior ablations. And we expect some lines which probably may or may not have gaps and therefore lead to the atrial tachycardia.
So now we can see also to the Afera. As we introduced, it is a unique combination of high density map, but also ablation catheter, which is able to toggle between PFA and also radiofrequency current. And I don't want to forget, and I also want to mention, we have technical support, a mapper, probably one of the best mappers we have here in Germany. It's Oke Warnolz, who is supporting us, and thanks for making it possible. We have now 7:40 p.m. in Germany, and thanks also to the team being here with us. I promise later on we all will have pizza together. Big thanks to the team. All right, in the meantime, I try to complete my map. I move the catheter around. The catheter is bidirectional, as you can see here, and it's got a D and an F curve. So you have a lot of versatility if you need it. So mapping is, something which can be nicely performed, and also due to the design of the sphere 9 catheter, as David mentioned, equipped with a total of 9 electrodes. We can also basically use maybe a virtual vector activation along this catheter. We will maybe have the chance later on to comment and to discuss that. So here now I am diving or moving toward.
Can I interrupt you as you're mapping? So, I think it's incredible to have a catheter that you can still get a high density map and not have to exchange. It's one catheter that you're going to map and ablate with. So I think there's definitely a whole lot of value to that. I see as you're mapping, you're mapping very quickly. How is the system validating that you have contact to tissue?
Yeah, this is a very good point. The catheter is lacking direct contact force measures. It virtually, or it calculates, and if you look at the catheter, you see different points and arcs around the catheter, and you also may appreciate this. You see it in the RIO and the right lateral view, this white point, and this white point also indicates that you are close, or that you're in tissue contact. despite of the fact it is not giving a true reading from, let's say, contact in grams as you may be used it from, let's say, regular RF catheters. Still, during the ablation, if you deliver energy later on, you will also see a certain temperature curve profile. And using PFA, we see, and we discussed it in one of the previous sessions, a slight increase in temperature. And this slight increase in temperature is an indicator of adequate contact to the tissue. Right lateral instead of left lateral, please, and RP. All right, and here now
So as Julian is mapping here, just to explain for our viewers, we're seeing already an activation map on the left side and we have a voltage map on the right side. So we get sort of both informations at once and we can see a lot of scar in the voltage map. This is what we expected and what may make this case quite challenging, to be honest. On the other hand, what we always also look at are the signals. So we, of course, appreciate the activation, which is displayed through the color or through vectors later. We also like to look at the signals from the catheter itself to see the fractionation, to see probably areas where we have a lot of the cycle lengths in a small area, which may lead us to the critical isthmus of the tachycardia. And
Julian and David, may I just interrupt for a second? It's Andreas from Hamburg. So first of all, very brave to select just such a challenging case as live case. Very good. I just have one question. If I have seen it correctly, you use a non-steerable sheath for guiding the mapping and ablation catheter. Is that correct?
Yes, that is correct. This is something we are used to because we also do it, for example, for single tip RF ablation. And with this catheter, you already get two curves anyway. So you have a D and an F curve with a bidirectional catheter. And I think this gives us enough versatility to use a non-steerable sheath in the majority or almost all cases, to be honest. Yeah.
Okay. And the second question, do you have any specific recommendations for the transeptal puncture? So do you target or aim for transeptal puncture at the posterior and inferior aspect as usually, or is it different from other platforms?
I would answer it. With this catheter, we aim for pretty much the usual posterior inferior aspect of the fossa. We, of course, need enough room to access the inferior part of the right inferior pulmonary vein, but because we also have access to this D curve, this should always be possible. So yes, we aim for the posterior inferior aspect. Now that you mentioned it, I'm curious, thanks for the question, and do you use a steerable sheath with a sphere 9 catheter?
Yeah, interesting question. Usually not. So our standard setting is not to use steerable sheath. It might be different in challenging cases. Just this week, we had a patient where we aimed at ablating a mitral isthmus, and we lagged on the stability at the mitral isthmus area. And that's why we have chosen a steerable sheath, but usually, just as you do, a non-steerable sheath.
PA, please.
Okay. Yeah, that's pretty much our approach. If we feel the need, then we would switch probably.
Hi, Julian.
Andrea, voice.
It's Andrea here. Hello. Thank you for having me here. Also, Devi, I didn't say hello yet. So indeed, from my part, also congratulations starting a case at 7:40 like this. So I have a lot of respect for that and also for the staff. I just have one question regarding the voltage cutoffs. So the patient is in flutter, and I see that you are using the 0.5 and 0.1 limits. Would you like to comment on that, in an atrial rhythm which is not sinus, and specifically with this microelectrodes, widely spaced distance, which cutoff do you recommend to use in sinus, which in APIB and which in flutter?
Yeah, it is a very good point. And it's also, I would say, an area of not full, let's say, agreement and a little uncertainty. I think this is something we have to admit. We know in general, and this is true as a principle, in atrial fibrillation, signals may have different different amplitudes. And if you just look into bipolar voltages, or voltages, it may be different compared to sinus rhythm. So this is a general initial, of course, point. And number two, all the thresholds we are using are basically, learned and traditional cutoff values. And there's, of course, in the end, it needs to be correlated to structural tissue. And therefore, I have to admit, it is, let's say, a cutoff which we keep on using for more or less traditional reasons. And also for the Afera, at least to best of my personal knowledge, there's no true, let's say, bench data or animal data which is super translated into the ideal, let's say, cutoffs for this type of catheter structure. And also due to its nature, it is also changeable in its conform. Also, therefore, I think it is something which is, of course, not as, let's say, easy to structure as compared to a regular solid tip catheter, for instance. I don't know, what is your thoughts on this, Andrea?
Yeah, I think that's the problem with bipolar voltage, that it's so dependent on so many things, starting from contact to wavefront direction. We have been seeing that in with other catheters also. But I agree with you. I just usually put it down a little bit to at least 0.3 or something. And I like to open the inferior limit just to be able to see inhomogeneous low voltage regions. But I agree, we have a lot of work to do to validate the voltage cutoff values, at least to be able to compare it to standard catheter, to understand what on the Afera, if I see a voltage map with a cutoff of or any kind of voltage. But for that, we would need in the same patient with two systems mapping and paired points, which are very close to each other, to be able to see the correlation and probably a kind of coefficients. But I have the feeling I also use 0.5 in sinus. In flutter, we usually use 0.3, and in fib we go even lower. If we want to see the cutoffs, the same cutoffs. But I agree completely. I very strongly also believe that the dichotomous voltage cutoffs are not, that's not realistic, that's not biological. So fibrosis is present in very different forms, and it totally depends on so in the normal hearts have fibrosis. So we should continuously adjust the voltage cutoffs to, for example, to see isthmuses in normal or even in a dense scar, in a heterogeneous scar tissue.
So maybe this goes back to the panel. Of course, we have an organized atrial tachycardia with a distal to proximal sequence in the coronary sinus. We have some, let's say, already signs for at least diseased areas. And would you now rely typically on activation maps based from the 3D mapping system? Would you rely on, or would you dare to do entrainment? Because this is all the questions we asked ourselves.
No, maybe I can start. I think it's a very interesting question. So first of all, you have a high density map, you have activation map.
Andreas, of course.
Yeah, at your right-hand side, you have a beautiful voltage map. At the left-hand side, an activation map. I think the black areas in your activation map already indicate that there are areas without any electrical conduction. However, apart from the great information that you receive from the system, I'm still a believer in entrainment maneuvers. So just to make sure that I really understand what the system provides of information, I would certainly go also for entrainment maneuvers.
Yeah, so from my part, I really try to finish first the full activation map. Sometimes I also adjust the activation criteria to take points, also to see the small, slightly far-fieldish points, and then I would also go for entrainment. Of course, we have reversible pause, but that I only use if I really have a clear idea about a small conducting isthmus and the full circuit. But I would also try to finish completely the map to make sure that we do not degenerate or change the tachycardia. Is that also your plan, Julian? Or?
Yeah, it was also exactly my plan and our plan, and we were hoping not to terminate the arrhythmia mechanically, because we know sometimes this also occurs. If the, let's say, activation map was not very conclusive, of course, we still feel entrainment is always a very good old but classic maneuver to at least to help us guiding our strategy.
So we see
So
that
Julian,
yeah.
Yeah.
So may I just ask you for a favor? I think the activation map with the Afera system looks a little different from what we know from other systems. Maybe you can explain just in some sentences what we see at the left-hand side. So what exactly mean those black areas, for example?
Maybe you do it. You have a lot of time while I map here. No.
I have some time, but also for me it's late. However, no, but I think for somebody who has not seen the system yet, it looks a little different. And then those black areas usually indicate that there's no electric conduction over those areas. So in patients, for example, having a box lesion or whatever, you will see this black quadrangle at the posterior wall, and that certainly looks a little different from what we know from the other 3D mapping platforms.
I think we can see maybe the mapper can show us the selection criteria about the voltage cutoffs, which is tagged as CAR. Normally it should be 0.05 if I am not mistaken. And then the active, because it takes, as you see, it takes a voltage point in a different way than activation points. So the activation points, it depends on the voltage decay, voltage change, and that can also be changed from 0.01 to 0. I think it's 0.02 volt per second is the change to avoid the inclusion of far field signals.
Kann der Warner das einmal zeigen?
Can we, yeah, well, I will forward this request. Can we see the voltage criteria for the LAT map, the selection criteria? No, for the, especially the acceptance criteria for the LAT map. This is an interesting question because I think it's important to, of course, as you already mentioned, understand that the black areas are not necessarily completely scarred. They may just not meet the criteria. Yeah. We have there may be small conducting corridors which in the end constitute a tachycardia.
Now, may I ask what was the energy source used at the first ablations, first two ablations?
There was radio frequency ablation, but not with this system. So these were conventional, I'd call it radio frequency 3D mapping systems.
All right. All right.
And Andreas' question, you guys have had the availability to use this catheter over this past year, and in the US, we've done
correct. So we just work a little.
Genau,
einmal
about their toolkit. Where do you guys? So many PFA. Where do you see the advantage? What do you see as the where do you see it being used? Where is it that you would say, that is what I want to go for? We'll let Julian work. We talk.
Well, for my part, it's we have been using it since last year in August with the intermittent pauses because of the availability of the catheter. But for us, we stopped using it during first procedures, so we only do this for redo pulmonary vein isolation procedures. And especially if it's, I also use it for first redo, so the second procedure. And I think that the advantage of the system is that the lesion placement, transmural long lesions can be placed with this catheter very, very fast. So I wouldn't use it for a paroxysmal AFib, only re-isolation. But for example, in these cases of previous lines, previous dilated left uterine scar tissue, I think that it's an amazing advantage that in these cases you can do the lesion placement of long for roof lines within just a few minutes, and we have a first pass isolation roof posterior line and posterior box about above 90%. So it's about 95%. And also it's an advantage, for example, that the posterior inferior line, you don't need to worry about if you want to have a box, you don't need to worry about the esophagus. We do take attention with the posterior mitral lines because of the coronary spasms. And the CTI line we only do with RF also because of the spasm. This is my approach, but I don't know if you have any different, Devi or Andreas.
No, actually, at our lab, it's the same. We started using the system about 1.5 years ago. And as most of us did, we also started with pure PVI. But I think the beauty of the system is certainly not PVI. I think that's the domain of single shot devices nowadays. So we especially use it for redo cases, especially for challenging ATs, such in this case here, because I think the really strong impact of the system is that you can really create very quick activation maps, remaps, that you can create rather easily and effectively linear lesion sets, especially an anterior line, mitral isthmus line. I mean, all of us know how difficult it can be to block a mitral isthmus line. From time to time, you have to go into the CS, ablate a lot from epicardially as well. And our strategy usually for those complex lines, for mitral isthmus lines and also for anterior lines, is to start with RF. And if we do not block with RF primarily, then we would also switch and consolidate more or less our line with PFA in addition. And so far, we did a lot of anterior lesion sets and could successfully block all of them. I cannot give too much information about durability. We did not have so many patients coming back with recurrence after previous Afera procedures, but I hope and guess that durability might be quite high for that system. And I think that really opens a new world, especially in a setting of complex ATs, of redo procedures and so on. So at our lab, it's not used anymore for first-time PVI, but only and especially for complex cases.
It's interesting because, in the US, the only use of this catheter has been part of the clinical trial. And we did PVI and posterior, most operators did PVI with or without posterior wall and, some mitral flutters. But it'll be really interesting to see how this technology gets used in the US as well. And I truly think that this is going to be kind of the catheter to go for redo procedures sometimes, mainly because I guess you have the flexibility of going between RF and PF. I just want to kind of ask a question about, and I know Julian's probably going to show us later, but where are there certain areas that you prefer RF over PF and vice versa when you're using this catheter? And I'll ask Andrea first, and both of you take your turn on it.
Yeah.
So in general, we tend to use only PFA simply because because we need to worry less about because I believe that it's also the transmissibility also in scar is an advantage as opposed to RF. So we only use it when we are afraid of coronary spasm. So basically on the right CTI line, the cavo tricuspidismus, we always only use RF, and if it's a long line, then we that's the only place where I think sometimes steerable sheet when the isthmus is very long is. I think I have used it, had to switch once or twice. And on the posterior mitral line, we pre-treat since this recent data with nitroglycerin if we use PFA. But I would use PFA, but that's arguable. If the posterior mitral, I think, is arguable if you start with RF and then PFA. I see Julian is waiting with something or not.
Discussion is exactly basically what we do every day in the lab. The same discussion. I was a little concentrated, but what I think what you were discussing. And we agree. I think it's not the PVI tool. It is for non-PVI repeat procedures. Cases like this, I believe this is a great tool. Even though, of course, you can do PVI, of course. But on the long run, maybe this is maybe for, let's say, understanding different types or certain arrhythmias, and understand the substrate. But moreover, and I think there's emerging data, okay, it's not atrial, but it's also on the ventricular level. And I can say we had a couple of, let's say, almost bailout cases, VT cases, in which we used it. we at least like the acute performance of the device. And I may have missed it, the discussion on the left isthmus.
Yeah, it wasn't really discussed. So what we heard now is that it's you start with RF there. I think we did both actually here. We had cases with both. We don't worry too much about the coronary spasms because we administered nitro before as well for the CTI. But I think there is a case to be made to start with RF, and if it doesn't work, switch to PF, which you already mentioned. I want to once again maybe emphasize the beauty of pulsed field as an energy source in general to penetrate scarred tissue. I think this can be underestimated. So especially in these redo cases where we expect a lot of scar, we just know that PF may more easily penetrate the tissue, even if it is very scarred, where RF may have problems with really creating the lesions.
So now we did work a little bit around our map, as you can see here. Again, we still have on the left, we have our activation. On the right, we have our voltages. And maybe we start with the voltages first. Maybe you can turn around. Yeah, you see there's a very patchy region at the anterior aspect. There's a very, let's say, low voltage area a little bit below. Maybe we go back to the posterior PA view. The PA, you see this, posterior wall, roof. There's at least an area between the left and the right-sided veins. At the roof still, there's some viable tissue. This is one thing I think we can learn. And now if you switch back to the activation map, please, Mr. Warnholz. As Andreas did indicate here, the black is probably the sick or the diseased non-single area. And maybe we can play the activation map. Okay, thank you. Now we see the PA view on the left side, and maybe you can show it on the right side also. And yeah, switch. Perfect, thank you. So we have an activation wavefront, which is running from the lateral, basically from distal to proximal CS, and then going from down up towards the roof. This is okay. Then and RP, maybe you can switch back to AP, please. And then go back to the roof. Yes, thank you. Here at the roof, we believe, an area of pretty slow conduction. And now it appears to me as if there were separating wavefronts. And we have one wavefront running around again, the left veins, and then down again mitral annulus, and one going down around the septal vein. So this is not so easy as to come up with the perfect analysis on this, but this is what I would make out of this at this point in time. Yeah. So what can we do more now? We can. I can ask, of course, my great pal. If you have any good idea, I mean, I know what we would do, but I would like to ask you first. Andrea,
maybe I can start. I can just fully support what you mentioned. I mean, it doesn't look too easy to understand. However, I think the roof, as you already mentioned, plays a critical role. So there's certainly some area of slow conduction. And then there's this colliding wavefront at the anterior wall. So certainly not as easy to understand, but as we already discussed beforehand, I mean, we have some other tools to verify if you're correct with our diagnosis or not. So maybe a good case to try some entrainment at the critical spots and see whether we are in the circuit or not.
So for my side, I see that roof, I mean, if you look at the propagation wavefront, it depends, the colors depends how you tag the window of interest, right? So it looks like that there is an entry into the left atrium, and from there a foci spread both medially and around to the appendage, right? I think, if I see it correctly. And then it goes around the mitral. Yeah, and then so I hope for you that this is not a biatrial flutter which enters via the previously not blocked anterior mitral line through the roof and then goes around the left and somewhere in the right atrium. I don't know if we have the full cycle length between the scenic and they're up there on the blue from I am not sure, but I would definitely entrain. I mean it's. But I would probably change the
agree
video.
this region is at least interesting. Let's put it this way, and it's a good point. Maybe it's the biatrial tachycardia, and we can, and this is what we would do. We see in our Afera a small signal here. So shall we go for and dare to entrain one time as proposed? Können Sie das einmal bitte machen? Einmal von T. Und die Zykluslänge ist 370, ne? Ja.
Now the other option is, of course, we have to make sure that the box there is no signal there between the purple and the blue on the box. That it's not there is some kind of small conducting channel there.
Okay.
Because I find it strange that the roof is being activated from the sept or the septal roof. From there, the activity is focally going somewhere. So the question is, where is that coming into there?
Yeah, that's what we are sort of wondering as well, and probably expecting that there is a small channel there we don't really see in the map, because the activation from the roof, from the top of the roof, is coming from posterior to anterior, which at least makes it possible that there is a small channel.
Good, mach mal.
Okay, we'll entrain now.
Yeah.
It is interesting to see that area. You would, if you look at that voltage map, simultaneously put the voltage on the other side. That is the area for the septal-pulmonary conduction. And if that was previously ablated area was transmural and we're just not picking up as well. But I think I saw there was channels in the voltage. I thought you picked up some voltage there.
Ja, mach den nächsten.
Actually, that's true. When we displayed the voltage map, we saw some small signals there with voltage, yeah. So now I missed.
So our guys, our friends say we had a perfect return right here. So we can move a little bit. Oh, now it jumped. Voila. Huh.
So I will have to say that, I've only used this catheter with the steerable sheath. And so, as Julian masterfully moves this without a steerable sheath, I feel like I'm going to have to give this a try.
I believe, as I mentioned, we are very used to working without a steerable sheath with the single tip catheters as well. So it was a sort of usual way for us to go to try without a steerable sheath. And because you have the two different curves available, and because the catheter is quite compliant and can really sort of move along the wall of the atrium, it feels like we most often don't need a steerable sheath with this catheter. I think we'll try another entrainment. He moved the catheter a little bit.
Now the signal is very, very small. It is unfortunately very, very small here. No, he will lose it. Here, we got it back. Okay. If you want to do it again, let's try.
We do one now. Yeah.
So it's a 370 the cycle length.
Did you look? Yes.
Genau. Und wie ist der Return? Aber es ist ja zu kurz, ne? Kürzer. Und das ist change.
No, you jumped again. Yeah.
So I think this is also underlies this case the importance of entrainment, because in the
maybe you show it again, and then the audience can see the entrainment because we don't see it at the moment. Andrea.
No, I was just saying that bystander
Yeah.
slow conduction is so frequent that it's. I think it's really important. I mean, that with entrainment, at least to at the region of interest on once the activation map is ready to.
You know what? We had very good entrainment here. We have. A map compatible with an interesting part here. We have to connect this area anyways. So I think we should come up to the part we were all interested, of course, into the ablation. Here on the roof, with regards to energy settings, what we typically do is we like for the anterior line, we like RF energy. I don't know why we use it.
Good question.
We use it, and it's sort of mandled out to be our preferred one. In non-anterior regions, we also are happy to use PFA at all sites. And I think we will start off with PFA here. Because also we know, of course, if you get very, very close to the phrenic nerve, always I get reminded, be careful with RF and switch over to PF. And this is why we would start ablating here with our first application. Okay, so we have on the Afera, we switched to the green, and we are with the catheter in position, and now we do ablate.
Oh, pace.
Oh, can you pay?
It's coming back.
Oh my goodness.
Okay.
Oh my goodness!
This is a complex case.
Off. Yeah.
Very nice.
I think a nice point to discuss is with PFA, we know we have a certain area of
switch
stunning
your
around our real lesion. So a certain area where we have probably reversible electroporation. And this area might be bigger in unipolar PFA compared to bipolar because the field strength is dropping off more slowly with the increasing distance to the catheter. So I think big challenge for us when doing these lesions with PFA will be to evaluate during the procedure how durable our lesions are. Do you have any ideas for that? Do you use a waiting period? Do you use a Danielson? Do you have any systematic approach to check if your PF lesions here are durable?
So maybe I can start. So we don't have any waiting period finally. Yeah? What we do is a remap certainly, but we don't have a specific waiting period. However, I fully agree. Nobody knows exactly how long we should wait or how long reversible electroporation might take. But at the moment, at least at our lab, we don't have a waiting period.
We don't have. I mean, if at the end of the procedure, if I'm in the same chamber, I one more fast check the activation map with the vector. But it looks like that it's within half an hour. So within hours, I think the general. I mean, what I heard, of course, we need to study this, but it's useless to wait because it's not with reversible pulse. We see that with lower energies, it's within the region of a minute, but with high energy pulses, I think it's rather it's going to take hours. We also have, as Andreas said, we have the same experience, multi-center experience also, that we have very few redo cases. And usually when we have, I have done about 3 or 4 of my own first Afera cases. And once we had a reconnection on the anterior mitral line, but the other 3 cases there was durability, and even the lesion size was exactly the same as at the end of the procedure, of the first procedure during mapping. If you compare the 2 maps, that was very impressive for me about this reversible lesion, that maybe there is a reversible zone, but maybe when the definitively taken force with the apoptosis, maybe the end result of the lesion size is pretty much the same that you do at the end. You see that the end of your first procedure, maybe. But these are all things that we need to study.
How often are you guys using, is it even possible to use a reversible pulse in some of these critical sites before you apply the whole PF lesion?
So we are a big fan of reversible pulse. Actually, I didn't dare to say it to Julian, but I would have tried the reversible pulse. The problem with reversible pulse is that it's a very low energy, very short duration application. But the advantage is that it's really reversible. That means that you're not creating, according to our knowledge, according to Jacob Korut's paper, surely not creating maximum superficial fibrosis. Now, the problem is what we have seen. We have a study coming out of this. If we get some interest into this, but so it works if the channel is superficial and the diameter is less than 1.5. I mean the width, the isthmus width is less than 1.5 centimeter at the current pulse energy we use. But I think it will be wonderful to have the possibility to titrate the reversible pulse. And I think it will replace, in my personal opinion, entrainment, because it's very useful in small, narrow isthmuses. And you can, without capture, you see termination of cycle length prolongation. It's 100% specific for the active circuit isthmus.
Kleinen Bonus, bitte.
And Julian,
There's absolutely
just
nothing
for the
better.
folks that are
Yeah.
not familiar with the features of the catheter, as you're applying the lesions, you can see the little blue ball come up. You got lines connecting those PF tags. Can you explain a little bit on those features of this catheter?
Yeah, the catheter is you see these green tablets. I call them tablets, which we deployed. And whenever you earn this green tablet color, the criteria, the defined criteria for good lesion or an effective lesion are probably met. However, you also need to connect lesion, and in order to create overlap, in order to avoid potential subsequent gaps. And therefore, the blue line, which you can still see here, is indicating that there is still a distance which is too large in between my applications. And the target and the aim is now to get rid of all the blue lines, or to prove in the end we have bidirectional block, and to trust in the quality of my lesion. You see here I'm a little struggling, but we are having, I think, a solid contact here, and we do a couple of PF applications here, and you see also the distance, which is in that green box. And this is telling and calculating the distance between its previous ablation. So here it's 2 millimeters, and it wobbles a little bit around. So it's a good help to, or it's a very strict algorithm making me moving around my catheter here in this very tiny region. And I have to admit, the transeptals here in this lady were a little more difficult in the beginning. You may see also that the transeptal exercise is with one very posterior. And another idea is sometimes to change it, to change the position in order to get better contact. But the idea is to get rid of the blue line, basically. Now I'm moving my catheter back into the appendage.
Already very late to the appendage.
Exactly. Here it's a long. Maybe you want to comment?
Maybe we can see the BART signals for the audience. So the pink or purple signals, as Julian mentioned before, are from the circular mapping catheter, which is now positioned in the appendage. And the activation of the appendage is very delayed. It's simultaneous with the QRS complex, which is not proof of block of the anterior line, but already a strong case for probably blocked anterior line, because this is what delays the activation there.
So what we can do in a minute is we may check for blocking this roofy part, what we are now aiming for. And maybe we will also be able to use later on the option of the calculated vector across the sphere 9 catheter. Oh, Daniel here jumped. Yeah, that was a nice one. And you also may appreciate, despite of using PFA, the patient sleeps pretty well. She's not moving too much, right? So thanks to, of course, our queen and princess.
Yeah. Julian, that's actually something that I just wanted to mention, because in our experience, it's especially challenging to apply the applications at the roof part, because that's the part where usually patients
That's
are
okay, oder, Herr Barnold?
applying energy. So I think this patient is really nicely
RP.
sedated.
RP.
Yes, absolutely. So especially when we're coming towards the septal PVs from the roof, this is where we sometimes have difficulties maintaining a stable position because patients start to move, then we probably capture the phrenic nerve. But here we are a very, very well sedated patient. Tachycardia, the queen of our cath lab, is handling this perfectly. So we're very happy with that. The patient is not moving at all.
Yeah, great.
I think it also helps set the lesions only for 4 seconds. So once you're there, you actually get to deliver it pretty quickly as well. So
yes, definitely. That's true.
So when we see the
We're right now
activation
preparing to show the...
in sinus, it already tells you that the line is blocked, anterior mitral line is blocked. So you just usually put in sinus up the catheter to the left roof.
Beautiful.
And if that part of the atrium is activated latest, then you can you can be sure that the anterior mitral line is blocked. Because the Bachmann is blocked, then the whole activation goes from the appendage all the way around the perimitral.
Yes, exactly. So if I make comment for the viewers who probably don't know the system already, so we can see this blue arrow at the catheter. This is a live calculation of how the wavefront is propagating along the electrodes of the catheter. And we're in sinus rhythm right now. The catheter is positioned at the base of the atrial appendage, and the wavefront is coming from the lateral inferior part of the mitral valve towards the line. So this is already pretty much proof of a blocked anterior line. If there were no line, we would expect the vector arrow to point into the exactly different direction. And I think it may be hard to do the same at the roof because we had so little signals there, but I think we will try.
Yeah, that is the problem. The roof part is very, very diseased or very low. Rechtslateral anstatt auf der, ja, genau, danke, genau, gucken wir nach vorne. You see here, in this part, anterior, anteroseptal, or at the right upper vein, we don't see any signals. So, yeah, what else would we do now? Would we try to induce some other tachycardias? I mean, we have 5 minutes left. we can do this, and then we spend we can with this. Maybe this is something to discuss. What is the end point in the end? Of course, one could. Of course, and this is what we did in super extreme cases, super selected cases. We also do tackle the left isthmus, of course. We know the left isthmus is a very important area. If you ablate it with alcohol, ligament of Marshall, or maybe with this type of energy, we feel this is very critical. However, if we would ablate it here, we would intentionally isolate the appendage. Given the fact she had, or we terminated this lady's, again, clinical tachycardia, it is still maybe not a very, very good idea to right away isolate the appendage. I don't know how you see it. I would be a little reluctant to do this at this point in time.
Yeah, I fully agree. I mean, this lady came only in AT. She did not have any additional confirmation of any atrial fibrillation episode or something. It was pure AT, if I understood correctly.
Ist doch super.
Yes, exactly. This is correct. This time she only came in atrial tachycardia. All documentation we have is organized AT, no AFib recurrences that we know of.
So
So
now
there's a
maybe
question from
look
the
at the
audience
EKG.
about GP ablation, and how there's concern with pulse field energy not really affecting ganglionic plexi, and is the bradycardia part of that? And so, Andrea, what are your thoughts about modification of GPs with
I think if
PF alone?
I think if it's the first ablation with RF, I wouldn't worry about that much. But it's a fact that when you do either with Afera or with any other PFA system, the first ablation, then you can be sure that the GPs are only transiently affected. So there is no GP neuromodulation. Now, in the patients who had first an RF,
Ja,
two RF
ja, aber nicht
ablations,
zu...
we don't routinely check if we can
Für
still
die, genau. Sag doch mal, jetzt bist du drauf, Andrea. Jetzt könnt ihr es sehen. Jetzt sehen es alle. Andrea is, in the meantime, Andrea Urbani, our Andrea, he is bursting a little bit in order to induce. If there was, maybe you do one, yeah, do one run. Show it to us.
Do one more. No, Andrea, do one more.
Andrea Urbani, you do live, please. Yeah.
Oh, yeah, we have to be careful with Andrea, and Andreas. This is confusing here.
That's the only name existing here in Europe. So.
One more time. Come on, let's be. Yeah. Oh, you're very aggressive.
I just have one question about this late activation of the appendage. So, do you routinely check the left atrial appendage flow, and what are your thoughts on anticoagulation? Although this patient had a CHATS FAST of 4, but if you would see, I mean, if you long term, even if the patient stays in sinus, and so what are your thoughts on that?
So maybe I can comment on this. After an anterior line, we would not routinely check the flow and then talk about an occluder just because of a reduced flow. This is, I think, something worth discussing because we definitely alter the hemodynamics with an anterior line, but it's not in our routine. Do you do it?
I don't, but I think we need to do more studies about that. So I think all of us who do anterior mitral line, we need to follow these patients, and it would be there is so little data what happens 2-3 years later. There is only one study showing that they had out of 100 patients, I think 4 8 strokes. So I think we need to work on this together, that after anterior mitral line, follow the patients longer, and it would be very nice if somebody would look at the consequential of the left atrial dynamics, I find.
Yes, most definitely. So I think there is a possibility to increase stroke rate with this due to the changed hemodynamics, but we just don't know enough about it yet. Of course, if we would isolate the appendage, we would always go for the occlusion. This was different now, yeah.
And it may also be a little different.
Well, we are almost running out of time. You got this case done in perfect timing. It's a complex case, and you made it look not so complex. But that was wonderful. Thank you to Julian, David, and your team in Frankfurt. Again, thank you to the Queen as well, because that patient looks very comfortable. Thank you, Andrea, for joining us. That brings
amazing
us
case.
to the end.
Congratulations.
Congratulations.
Great case. Again, that was a great session, but there's still much more to come. So please stay tuned and stay with us.